Good morning again. Welcome to our plenary session. So the topic of our panel discussion today is a very important topic, mitigating the impacts of COVID-19 on reproductive, maternal, newborn, child, and adolescent health services. As far as public health crisis with devastating impact on the health and other sectors is concerned, we have never witnessed before one with the likes of COVID-19 pandemic. As of today, February 2021, the pandemic has claimed over 2.4 million lives, and more than 2,000 are from our country. It also affected us closely. We have lost members, active members of our society to this pandemic. So the challenges are really immense. On top of that, it has an immense impact on the essential healthcare services. The RMNCAH healthcare services are one of the highest affected, highly affected areas with this pandemic. ESOG, as a professional society, believes in updating its members on the current status, the recent development, national directives, international experiences, lessons learned, and the way forward for tackling this global public health challenge, specifically in relation to RMNCAH services. Hence, we prepared this panel discussion to address this issue and many more issues. With that being said, excellent for her excellent leadership in the health center. Please help me welcome Sister Zamzam Mohammed. Dr. Thank you so much for coming, Sister Zamzam. Dr. Yirgu Gabrahiwat is an associate professor and consultant obstetrician and gynecologist with subspecialty in gynecologic oncology. He also has a master's degree in epidemiology and biostatistics. He has served the Department of OBGYN of Addis Ababa University and as a head department, and the Ethiopian Medical Association as president, and the Ethiopian Society of Obstetricians and Gynecologists. He is a founder of the African Federation of Gynecologists, and he is an officer at the FIGO. He had more than 40 publications on peer-reviewed journals, and he has multiple other contributions with regard to guidelines and books. He's currently serving the College of Health Sciences of Addis Ababa University as Clinical Service Director. And I welcome Dr. Yirgu Gabrahiwat. Please help me welcome him. Welcome, Dr. Yirgu. Dr. Mahalet Igaramu is an assistant professor and consultant obstetrician at the Addis Ababa University College of Health Sciences, Department of Obstetrics and Gynecology since 2004. She holds a medical degree and a specialty in OBGYN and master's in reproductive health and sexual rights. She is currently a fellow in reproductive endocrinology and fertility program at AAU. In her 13 years of experience, she has been an active clinical teacher of both medical students and residents in obstetrics and gynecology, and published over 18 articles in local and international peer-reviewed journals. She has served into diverse administrative positions at the School of Medicine, and she had been a clinical director and department head to the Department of Obstetrics and Gynecology, and a dean and CEO to the School of Medicine and at the Gorambasa Hospital and at Addis Ababa University. She is the chair of the graduate program in the department and a Senate member of Addis Ababa University. She is the chair for the examinations and certification committee at ESOG that conducted 2 national in-training examinations in the year 2018 and 2019. Dr. Mahalet Irgaramu. Thank you. Thank you very much for coming. Ato Ababa Shiburu served as a country director at Maristops Ethiopia program since July 2020. Before that, he served as a country director from 2016 to June 2020 for Maristops Zimbabwe, also designated by the government of Zimbabwe to serve as Family Planning 2020 Civic Society Organization focal person for Zimbabwe. Before he moved to Zimbabwe, Ato Ababa also served as deputy country director and director of programs and director of research, communication and external relation for Maristops Ethiopia since 2010 to 2016. He has over 20 years of experience in public health programs, including maternal and child health, HIV/AIDS, PMTCT, family planning and reproductive health, malaria prevention, and gender programming. His career includes positions in Maristops, Cambodia, as an assistant to the country director, US Peace Corps Ethiopia office as deputy country director, IntraHealth USAID as project manager and team leader, ActionAid Ethiopia as program officer for community-based healthcare, and the Catholic Church Healthcare Program as MCH nurse. He holds an MPH, a master's MBA in health care management, and a BSc and an advanced diploma in comprehensive nursing. Please help me welcome Ato Ababa Shiburu. Thank you all for being positive to participate in this important panel discussion. Just to keep the flow of the discussion, I'll start. My first question goes to Sister Zamzam Mohammed, because she's from the ministry. So what do you think, and how was your experience? What is the impact of COVID-19 on RMNCAH services? What is the reality in the ground? What challenges did you face, and what successes did you achieve?
Okay, thank you. Just first of all, I will try to communicate the message from Dr. Masarat. She has another emergency commitment by the ministry, which delegated ministry, to develop COVID-19 materials for the upcoming situations. Because of that, Dr. Masarat says to you, just thank you. And as well, she can't attend the meeting or your annual conference. She feels sorry, but she congratulates you. I start what is going on in real scenarios at the ground related with COVID-19 fact, with RMNCAH service in our context. First of all, just like other countries, Ethiopia face similar, which is a newly pandemic, which is globally after 100 years after swine flu, the first infection, which is making the globe which at risk for a number of economic, social, and other impacts. So Ethiopia is part of it. So what we faced is at central level, when the disease enters to our country, and knowing at the month of March, we try to just see ourselves as a ministry from the central level. Then we try to communicate at different level. There is a management, and also as a directorate, we try to communicate what we try to contribute to prevent the collateral damage which is occur with the COVID-19, especially the essential service, specifically to RMNCAH area, how to avert the conditions which is happened to our country. We communicate and take a message alone, everybody individually contribute for that emergency issue. Then we try to just communicate each other and just even communicate at the regional level. And then we try to see what what the ground, the service delivery point, it looks like related with the COVID-19. Then there is a task force nationally established. In one way, the COVID task force, and the other way, the RMNCAH service task force at all levels, from the national till the community level, health post level, there is establishment of the task force, and then organized teams and develop different teams, and going out and observe what the ground looks like with the problem we are faced. Then immediately when the team just go out for supportive supervision, what we were observed that the service all are fragile, almost because of fear of the infection transmission, and just even the preparedness, which is try to handle the situation, it needs a resource. That means specifically for personal protective equipment shortage, and even there is a shortage for essential medicine, and some facility is just designated for COVID isolation and a COVID treatment center. Because of that, almost in the ground is just make me worry at that time. Then we came back and developed the interim guide and RMNCAH, non-COVID essential RMNCAH service guides developed, and try to mitigate how to just handle this essential service. If not, we are facing a challenge. When just what we observed on the ground is maternity waiting room was locked at that time. Even some of the maternity waiting room is not functional even currently. The other thing, mothers deliver at home. Because of that, we lost a number of mothers because of this pandemic. Then what we are going to do is that just this essential health service non-COVID material is developed and communicated to the regional responsible person. That means the regional bureau health head and the deputy and the other, they try to just perform the activities based on that guidelines. Then after that, when we are just classified and formed a team, which is seeing out for how the service is going on. After a certain, especially March and April, the RMN service performance is going down. That makes us very worse, worrying for that. Then after this material is developed, communicated, and try to perform the activity based on that guideline. After a month or something, when go out and observe the service which is provided, it is a little bit better than what we are seeing before. So what our success is immediately when the disease occurs, as a ministry central, the management is just swift, actively try to reverse the problem, just developing a number of resources like different protocols, how clinical management is given at the facility level, especially hospital and health center, even at the health post level, and the other infection prevention material, national action plan material is, this plan is developed, and the other issue, different guidelines for the long truck drivers, just looking the borders and so on. After that material is developed and certain team is formed and go to all regions to support and develop communication materials like tailored risk communication and community engagement at all levels, that all things try to change what just previously seen when go down and observe everything was previously collapsed. After this material is developed and sensitizing people through the mass media, using leaflets, television, radio, and this awareness creation. Also, it is one of the success, which is a little bit, still now there is a problem, as we communicated before, the behavior of the people sticking what during the disease, the infections are entered to our country, and after that, immediately people are trying to protect themselves, that the safety measure like social distancing, using a face mask, and avoid crowded area and the meeting. These all things may a little bit, it has, it brings a change, and we can say that one of our success. The other issue, what our success is, just provision of vaccination of MCV2, measles vaccination 2, which is provided or vaccinated, just plan around 50 million, but we try to vaccinate it around 14 point something million. This is also with that burning environment, with that COVID situation. This is one of our success, and the outcome after developing and just introduction of that different material also, there is a little bit, the service a little bit, it shows that improvement. The other success is just communicating with different sectoral office, because this problem is not solved by the Federal Minister of Health alone. It has, because of the strength of the ministry, which is try to communicate with a multi-sectors, especially with pharmaceutical part to perform different industries, the textile industry changed to the mask, and the other thing, the other industrial parts, the detergent factory also try to develop a number of products by supporting, by the government support, giving just monetary and other issue, try to just produce the detergent also. There are school, especially the pharmaceutical unit, is try to just made sanitizers and others. This also, I can say that it is our success. The other issue what we are observed as a challenge is during the pandemic, the infection entered to our country, immediately everybody is turning their face to one thing, even the professionals, because of some gaps on the information, they fear and not enter to the facility, especially at the lower level. Because of that, there is a collapse to some extent, especially the March and the April. And people are fearing to go to the facilities because of fear of healthcare providers has already acquired the infection, and they thinking that they transmit infection from the healthcare provider to the our clients, especially for pregnant women. The other thing what a big deal done is there is an algorithm which is developed by the ministry and Ethiopian Society of Gynecologists and the Ethiopian Midwife Association, which is how to pregnant and laboring mothers has follows their antenatal care and so on when they transport, how to take a safety measure during transportation and so on. Then there is ACBCC material is developed for the general community, including healthcare provider with a pregnancy, that different materials support just change the understanding of the people, how to save their life, and even how the healthcare provider support the client. There is non-COVID essential materials also focusing on different areas, like how to provide antenatal care with normal, a mother with no risk and with risk, how to just attend a delivery, postnatal care, malaria, nutrition, cancer, and other non-communicable diseases like cancers, hypertension, diabetic, and so on and so on. For that specific the clients, how to handle the situation by healthcare providers to get a direction or to just to give a service with a precaution. These all materials are just a big changes on our success. The challenge is like other issue. There is a limitation of shortage of logistics, especially essential logistics for the mothers. There's also the challenge is blood and the blood product and the facilities. To do all this, the COVID-19 situation brings a number of challenges as other countries faced. The other, what we said that ventilator was not enough in all hospitals. So these all things as one of the challenge, but we try to mitigate the situation by communicating with international communities and even in our country. This is the best one. We can say that a success. The students of universities and colleges try to do by what the resource at hand, developing a ventilator. This by doing this and by mobilizing a resource, we try to mitigate to some extent our problem. But still our challenge is our community's perception about the disease, about the infections. So you see it that when the pandemic is happened, the people are taking care of themselves. They are using social distancing, just avoiding the crowded end meetings and so on, using a face mask and so on. But nowadays, there is a behavioral problem to use these safety measures. So this is also one of the challenge. In the future, we try to communicate and try to solve the behavioral, because it is difficult to change the behavior or the behavior of the people to sustain what they already informed. So we try to do, everybody in this room has, and everybody in the nation has tried to just involve and contribute to avert this infection. If not, we face a big challenges in the future.
Thank you very much, Sister Zamzam. Dr. Yirgu, so you have been in the leadership position in one of the biggest hospitals in Ethiopia when the pandemic hit, and to this date. So how was it like? What is your experience with regard to deploying your professionals to fight the pandemic, especially in the earliest times? Logistics, such things. So how was your experience?
Good morning to all of you. There were a couple of issues as we embarked on the COVID era. Now, the first issue is that this is something quite unknown. In fact, nobody knew exactly what is coming. when it's going to come. In fact, when the first case was detected in the country, which was March 13 on a Friday, we were called for a meeting to orient our staffs about what COVID is all about and all the preparations that we need to deploy in order to handle such issue. So that was the level of preparedness, even at a country level, okay? We're not prepared, the least that I can say. Now, once we knew that COVID is coming, then what is the next step to combat with the situation? So we had a series of brainstorming sessions within the management. And then we realized that the existing management structure within the college is not good enough to handle such an emergency. Rather, we need to formulate an emergency operation center, EOC, which operates along the whole College of Health Science. As you know, College of Health Science has got 5 major units for our schools: School of Medicine, School of Pharmacy, School of Nursing and Midwifery, School of Public Health, and then definitely the largest hospital, which is Tukrambasa or Black Lion Hospital. So all the 5 elements of the college have to be able to move in tandem. And then we have to use all the local knowledge and resources available. So we established the EOC. This is around March 16. And then we had our first meeting on March 18. Remember, this is within 5 days of detection of the first case. And then the next step that we did was we did an environmental scan, an assessment of what do we have, what is missing. This is in terms of PPE, in terms of surveillance, in terms of treatment facilities. Between March 13 up until today, we have added only 5 ventilators. All the ventilators that we are having are the already existing ventilators. Okay, again, this talks loud about our level of preparedness. Now we are having quite massive number of cases. We have got a huge number of patients that require mechanical ventilation. However, the resources are still quite limited. And then the next step that we did was we did a comprehensive planning. The EOC had almost 12 units within itself on the various aspects of preparedness, including case detection, including surge capacity, including infection prevention, psychosocial support, pharmaceuticals and logistics, communication, etc. So all the 12 units move along a predefined line, yet we meet again to see whether we are delivering what we have intended to deliver. Now, that planning exercise has been quite useful because by then, even we don't have a national plan. So we had to go to the Federal Ministry of Health in the presence of the State Minister and the directors. We showed what our plan looks like and the resources that it may take in order to handle COVID at a tertiary facility like ours. It has been quite an input to the ministry by then. Now, however, despite a detailed planning exercise and describing what it takes in terms of PPE, what it takes in terms of medications, in terms of surge of ICU capacity, conditions are literally the same we have not got the support that we essentially requested. Now, following the first case, as already stated, during April, there is quite a restriction of movement in different regions of the country. And then access to services were quite limited. We're doing a daily count of a number of patients that are visiting. And by the third week of April, in fact, the daily patient load along the whole, this includes obstetric care and other services, were curtailed to 50% of our capacity. This is because there was a predominant fear in the population, fear amongst health workers. There is quite a restriction of movement. Definitely, patients who were supposed to come to us were not literally coming. And that was really a disturbing moment, because on one hand, we have to fight COVID, its consequences. But on the other hand, which is equally important, or even more important than COVID, was maintaining essential services, okay, like oncology service. There is nowhere else. Maternity service, even in Addis, we have heard of women who are delivering at home and women dying even at home. So that was really quite a scary moment. And then that was like a moment of awakening when FMOH made a decision that Tukur Ambassa is going to continue to serve as a non-COVID center. And this specific designation of being a COVID and a non-COVID center came around with all its consequences. Then what happened? Between March to August, cases were trickling. We are identifying patients who are COVID positive after they have been admitted to the hospital. And then the surgery cancellation rate goes up to almost 70%. The reason being, patient is coming, they get tested. And, by then, the turnaround time for COVID tests were on average 5 days. So by the time the result is available, and patient is scheduled, then, physicians know that these are COVID positive cases. And then the cancellation rate really rose quite high. In fact, one day, I remember amongst 8 pediatric cases that were scheduled, 6 were positive and they had to be canceled. So then we have to reorient the way we do our business. What do we need to do? We need to start an in-house testing. So Tukur Ambassa started in-house COVID testing on its own without any assistance from any other entity. In fact, there was a hurdle. The hurdle was because you have to get approved by EPHI to be a testing center. We're told, okay, this is a site good enough for testing, but you do the test only that we provide you, okay? They collect all the tests, it goes to EPHI, and then EPHI ration the testing across the city. We said, no, we are not going to do that. Even if you are, the authority which gives permission, we need the testing capacity to do testing for our patients only. Okay, that really reduced the turnaround time for COVID tests to less than 24 hours. Then in August, when we do the daily count, we had about 24 cases of COVID patients with other comorbidities, which cannot be handled by any so-called COVID designated centers. The centers were telling us, okay, we can treat the COVID, but we cannot treat the malignancy or the additional comorbidity because we don't have the specialty, we don't have the medication, etc. Okay, so it doesn't matter, what kills a person. Once a patient is dead, it doesn't matter whether this is COVID or whether this is a malignancy. Okay, so when we had these 24 cases which stayed within hospital with a COVID positive test result, staying for about 18 days on average, and we make a decision. And we went to the ministry, said now it's time that we integrate COVID services within our facility and do an integrated COVID and non-COVID services. The point of this is, maybe Dr. Malet will elaborate on this. We had one very interesting, very challenging experience of a woman who is COVID positive, morbidly obese, with severe preeclampsia, which needs intubation and mechanical ventilation. And then this woman cannot be transported from her bed to the OR because the fear was if for any reason the endotracheal tube gets dislodged, then it would be exceedingly difficult to reintubate this woman. And then she has to be operated on her bed. Unfortunately, the lady passed away after a few days, yet the neonate survived. Okay, so that led us into the second phase of our task of reintegrating or integrating COVID and non-COVID services. We have already availed now 2 floors for COVID services within the hospital. So what is the output of all this exercise? We have produced a number of teaching materials that have printed materials, as well as audio-visual aids. We have, in fact, started sanitizer production prior to the COVID era. That was like literally a manual process. Now we have a semi-automated process of sanitizer production, which produces about 3,000 liters of sanitizers per day. But we are moving forward to a fully automated production, which will materialize in a very few days, totally automated, and with a production capacity of about 5,000 liters, 50,000 liters per day. And this would enable us not only to supply the hospital, but also other facilities around us, and also avail it on commercial basis. We have trained other facilities like the Army. The whole management of the Armed Forces Hospital came to us. We showed them how the EOC operates, and they have had an in-person and first-hand experience, so that they establish the same within the Armed Forces premises. We have 39 bulletins. This is a 44 weeks exactly of COVID. We have 39 bulletins because, as you know, all of the informations that we use for whatever purposes are information that we gather from the outside world. We don't have a local information. So we started right from the very start producing our own bulletins. If you are interested, we can avail it also online or provide it to ESOG to see what is happening locally, what is happening in terms of COVID as well as non-COVID services. We have some research outputs. Already there are about 4 publications in peer-reviewed journals. Definitely we are going to produce more research outputs based on local evidences. What is the challenge? The challenge is still we need to reorient more resources to combat and contain and mitigate the effect of COVID. There are shortages I've been crying like for 4 or 5 months now. Nobody is listening. There is no gloves. There is no gloves even in the market. Okay, the gloves that we are having are hoarded by merchants who have fixed the price, who have fixed the minimum quantity that you need to procure. Okay, this has to be seriously addressed by the ministry so that PPE is properly supplied to facilities like ours. If you look at the positivity rate, again, this is a challenge that came with that designation of being a COVID and a non-COVID center. If you look at a COVID center, the majority of the health workers are protected. If you look at the number of positive rates in the COVID centers, there are very few. I've got nearly 120 staffs who are COVID positive, okay? Because we could not provide the necessary PPE to our health workers. So the Ministry of Health has to seriously think about this. Now, the other challenge is the issue of incentives, okay? I understand why a facility is designated as a COVID center and someone else is designated as a non-COVID center. But no patient will come with a clear label on the forehead saying this is a COVID patient, okay? So if you sit at the emergency, you are likely to encounter a patient who is COVID positive having some other comorbidity. If you sit in the antenatal OPD, then you would have a patient who is COVID positive and coming also for antenatal care, okay? So because of this designation, I think Ministry of Health can defend itself, but none of the incentives are coming to our health workers, okay? Now, there is a difference between federally managed hospitals and regionally managed hospitals. As you are all aware, for example, the Addis Ababa City Administration has exempted its health workers from not paying income taxes, okay? Whereas our health workers being managed at the federal level are not getting any one of the incentives, okay? So we are serving the same population. We are working in the same geographically defined space. However, the treatment of health workers is entirely different, both at the federal level as well as regional level. Even within federal facilities, there are some differences. I will not talk about the details from here. I think the other challenge which we have come to realize is that probably initially we thought, COVID is something that would go away like in a week, 2 weeks time, but we are not really accustomed to the fact that we are going to live with COVID. I don't know how long, but in terms of preparation, okay? In terms of, now we see in the immediate recent past, our positivity rate was in the range of 9 to 10%, yes? But our positivity rate currently is standing at around 14%, 14, 15%. The number of patients in the severe category are increasing. Our capacity, our preparedness is still quite limited, okay? One of the areas where capacity is limited is in the ambulance transfer and communication. If you have got a critically sick patient, you want to transfer this to one of the COVID centers, it's virtually difficult. It's virtually difficult because we have, these long vehicles with no facility inside. So what you have is a nurse, probably an oxygen cylinder, and then a driver who runs around, okay? None of our ambulances are fitted to do life support. So we need ambulances that provide comprehensive or advanced as well as basic life support. the issue of PPE, I cannot emphasize it enough because this is really quite a shortage that we are having. We need to have access to personal protection equipment. I think these are the issues from my side. Thank you.
Thank you very much again. Now I want to first address the service issues, and then I will come to Dr. Mahalit for the teaching learning activity, yet another very challenging area. So at Ababa, so many health facilities, I mean, almost all health facilities had to design some adaptive strategies to adjust to the new problem, the pandemic. And now I know Merstops is one of the health facilities that tried to adjust and design some strategies and implement them boldly to adjust to the system in general, to the pandemic and the situation. Though it's very difficult in our, in a country like ours, challenges are immense, I understand, but yet we get opportunities as well. We can even implement them in the future. So you can just summarize what you have done with this regard to the use of telemedicine, for example, for the service and other technologies. And what did you find as a challenge, and what opportunity in particular did you find in that?
Okay, thank you very much. I think it is the right time to say good afternoon. Thank you for the opportunity, and I would like to congratulate ESOG for this novel opportunity and a timely session. And when it comes to the question that has occurred to me on the telemedicine, sometimes we're referring, telehealth. And before we proceed to that detail, I think as Doctor mentioned, we don't know when COVID is going to be stopped. So if you are talking about adaptation, we have to think of three major scenarios with regard to COVID. The first scenario is COVID continue with existing pace, with existing volume of, catastrophe. This scenario one. So with this scenario one, what kind of adaptation strategies that we need to follow is the first important thing. The second one is might be COVID no more an issue after 6 months. So that means we are free after 6 months, which is unlikely. So what kind of adaptation strategies that we need to think of? And the third one is COVID might exacerbate it, undermine the socio-economic development. At the same time, it undermines the health and well-being of women. That's why we are here today. So these are three scenarios we have to think of. So in these three scenarios, one of the most important thing is technology. As to me, one of the incentive of COVID is that it pushed us, it influenced us to think differently. The comparative advantage that we have over the last several years before COVID, it doesn't mean that it's a comparative advantage for us. So that means we have to transform the way we are doing business. If we are transforming the health care industry, I think, for example, in organic setup, the first wind of transformation is culture, practice in that particular organization. The second wind of transformation is technology. So if you are talking about COVID vis-a-vis RMNCAH, the critical part that we have to think of is how can we use COVID as an adaptation strategy? It's not only because of COVID, but as I mentioned earlier, because of one of the incentives is just we have to think of how can we use technology during and after COVID. If we are lucky enough, if COVID is no more an issue after several years, that doesn't mean that we have to go back and do the same kind of things what we used to do. So from that point of view, if you know, or if you remember, or just we all know that telemedicine is not a new phenomenon, but in practice, it might be new for us, but in principle, it has been said a long of time, just for several years. For example, if you find the literature, it says that in America, for example, more than 70% of the gynecologists, they are using telemedicine as one of the approach, as one of the tools to serve their clients. If you go to UK, the same kind of stuff. But if you come to in Africa, the only country that might use telemedicine at micro level is South Africa. But the rest of us, just we are talking, but we are not doing because we don't have that capacity. But that doesn't mean that we have to stop to think. But COVID influenced us, at least to start on what we have. I mean, to start on what we know and build on what we have. Whatever technology system that we have to take it as an opportunity. Otherwise, COVID might not be something that we are taking as an excuse not to use technology. So from that point of view, for example, in Marisop's context, I would like to give 3 scenarios, 3 experiences. For example, our home office in London, they are using, or we are using, telemedicine as one of the approach, particularly for early medical abortion for 10 weeks and before. Because telemedicine was not practiced in the UK, particularly for early medical abortion. But the governments, they considered most of the women, they are afraid to come to the health facility because they are afraid of, catching, the COVID. So they declared for a short period of time, women can access or can use early medical abortion at home. So Marisop's just come into a picture, introduce telemedicine approach. So that telemedicine approach that enabled our providers to interact with the clients, eligibility criteria, safeguarding assessment, all those things have been done through telemedicine from the doctors and the patients or the clients, they are interacting using this teleconference or telemedicine, so that after the woman, for example, if the patient or the client she's eligible for the medical abortion, she can access the service, the drug, through the postal office, or she might come to, based on the regime, to come to the health facility just to pick up the product, and then she will be supported by a teleconference advice. So by doing that, most of the clients in London, more than 60% of the clients, they are receiving the services through this teleconference or a telemedicine. So that means still those women who are supported by this kind of system, they witnessed it is reliable, it is safe, and at the same time it is very easy method. So most of them, they say that I'm fine with this one, but I'm advising or I want to continue for other services even after COVID. So that means this is one of the opportunity, the incentive that COVID to bring for us to use telemedicine as one of the healthcare industry transformation. And when it comes to Ethiopia, we are using the telemedicine to some level and reaching those clients that we are serving. For example, we have what you call it telehealth center or client contact center that's serving clients through information on medical abortion, on maternal health, child health, and family planning and other reproductive health, including HIV/AIDS. So we are reaching more than 85,000 women every year through this teleconference, telemedicine. But this is in the normal scenario, in the normal circumstances. But after COVID, we found out the number of women who have been calling us for services increased by 35%. Because they felt that they may not able to go to the public facility, but they want to get some kind of information. How, when, and what type of drugs she might or he or she might look for the service that she's looking for. So from that point of view, the 85% increased by 35% on annual basis, on regular basis because of the COVID. So as a result of that, what we did was we are providing counseling on those stuff which I mentioned earlier, on RMNCAH, maternal health, child health, HIV/AIDS, safe abortion, even to the extent of we are partnering with UN Women, and then we are reaching those sexual abuse survivors. We are supporting sexual abuse survivors through counseling, advice, psychological support, and referral. So over the last 6 months, we managed to refer more than 34% of those clients who called us for services. So because of that, those women are able to get that service. Because before she transferred or before she referred to the nearby health facilities, we provided a regular counseling, regular advice, and at the same time first aid management. When I'm saying first aid management, if for example someone is bleeding for some reasons, she called and she's saying I'm bleeding, what can I do? Then our providers, they are providing that kind of counseling and then they refer to the nearby facilities. So that's why I'm saying the first aid management. So this is the critical component that we have seen. The number of women who have been receiving telemedicine support is increasing. And as an organization, we have learned that telemedicine should be one of our integral component if you want to reach as many clients as possible. Now, the main challenge could be if you are talking about telemedicine or telehealth, that should be supported by technology. So if you see our country situation, the internet penetration rate is around, or the number of people who are using internet is said to be 24 million, but the penetration rate is very, very low. So this might be one of the challenge that if you want to reach at larger scale, this is something that we have to think of as a challenge. The second one is, of course, the mobile users now reaching about 40 million, but that doesn't mean that all of those have been using mobile for one other reason. So this is one of the challenge. And the other thing is the frequent internet interruption or the accessibility for internet is something which is very limited. So if you are thinking of telemedicine at a larger scale, this is one of the challenges that we have to think and how can we address this one. And the other thing is, as I'm trying to mention, telemedicine is aligned with technology, but most of people, more than 80% of women are living in the rural part, they may not have that kind of facilities. So the challenge is it is technology divide. So that means we are only reaching those women or those people who have that access. But most of the needy women are living in the rural part of the country. So what kind of telemedicine support that we have to think of? This is something, an assignment, is a takeaway message for us as an organization. If you want to reach the poor and the disadvantaged through technology, what are the strategies? What are the strategies that we have to think of? This is the critical strategies that the critical, what you call it, challenge that we are facing. And of course, as I've tried to mention, COVID gave us an opportunity to think differently. So if you want to make a difference in the rural women, what kind of technology service that we have to think of? This is one of the area which I would like to convey. The lesson I have, which I would like to draw or I would like to mention is from this telemedicine opportunity or the COVID opportunity is by hook or crook, telemedicine should be a way to go, whether at small scale, at larger scale. We have to start on what we know, as I mentioned. We have to build on what we have. So let's build on what we have, and we have to reach many women through such kind of services. So this is the lesson from Microsoft that we have learned. There is a huge need for telemedicine, but a huge limitation in terms of accessibility. So accessibility has to be addressed through different means. And again, the telemedicine should be considered as an integral component in the National Health System Development Program. I don't know to what extent the government has a telemedicine policy, but if that policy exists, that's fine. But I'm not sure there is okay, if that's the case, we have to translate, we have to transform that policy into action. But sometimes policy by itself means nothing unless we transform to the implementation. So in general, telemedicine is the way to go as we are thinking COVID before and after.
Thank you very much. Dr. Mahalit, so you've been coordinating the medical training as well as the residency programs. Like we said, it's one of the areas that has been challenged so much. But I know you have been making efforts to, adjust to that. So what actions did you use, to continue the training programs, and what were those strategies, and how effective were you in applying those, and what did you get from that as an experience?
Thank you very much. Good day to you all, and thank you, ESOG, for allowing me to be one of the panelists. I'm given an area that is very important, but least vested on, because during the pandemic, focusing on education is not in the top lists, because the service is the one that is prioritized. And the OB/GYN residency program, like other clinical or surgical residency programs, is going to be affected with COVID, because residency by its nature needs a competency that has to be acquired during a given time. And it has, as you all know, it has 3 pillars. Okay, the teaching, learning, acquiring basic knowledge, advanced knowledge relevant to the discipline. Okay, service provision as it at the level applies, and undertaking and understanding research. So this is the novel curriculum that we used to give residency OBGYN training in the country for the last maybe 25, 30 years. And as a country, unlike other like Central African countries, our experience with pandemic, let alone COVID, but other, recurring pandemics is very low. So Ethiopia has never seen anything like this or closer to this that could affect the teaching, learning, and especially the residency program, okay? So our curriculum is in no way prepared to face the challenge that our residents will have. Another thing to note is that residents in other like developing countries, they are not frontline health providers. They are contingencies to the frontline providers. But when you bring it to our reality, residents are actually the frontline health professionals in most teaching institutions. Okay, and of note again is since recent years, maybe for 5 years, our residents are coming with very limited exposure to the obstetric and gynecology practice during their general practitioner era. Because that field is being covered by other health professionals. So the residents that are coming to us, and currently they have least exposure to the obstetric practice. They are in the era of a pandemic where our curriculum has no flexibility per se, and they are expected to give service, not to get the learning first, because in the pandemic, the axis shifts. There will be, the axis shifts in a way that the resident should be a primary care provider first, then the system should maintain the health of the resident to drive the service, and continuing the education without compromising quality will be the third order. So it is not easy. It is not easy to run a residency program in our situation because we are held off guard by COVID because of our existing infrastructure. Most of our service is still manual. Our patient service is by the bedside, okay? And our skills are acquired in the operation theater where we have a group of residents and the skill transfers will be on hands. So it is very easy to understand that residency programs will be handled very differently in a country like ours. Another thing related with COVID is, as Dr. Yirgu has put it, patients fear us, we fear our patients. We don't know which one is giving and which one is taking, okay? So that creates an anxiety. There are international literature evidences that the anxiety level of residents and poor stress management of residents could reach up to 50%. And we have no way of handling that. Okay, we have no handle. So during this difficult time, I think I have been leading a good program because the College of Health Science was trying to help programs run alongside the clinical services. As Dr. Yirgu has said, the formation of the emergency operation, I think it's called center, yes. It has been guiding not only the service and the health provider, but also the teaching learning programs. We didn't have protocols on how to handle the situation. So the EOC provided weekly brochures and daily updates, especially the first 8-10 weeks. We had daily updates on how to handle incidents during the service as well as during the trainings. Our residents were the lead anxious. We have residents who say that they have symptoms and we didn't have a test to confirm or not and to place them in the workplace. The guidelines on how to treat the suspect was not clear at the beginning. The month of April was the craziest, I cannot tell you. So that the leadership by the EOC and the later acquisition of the testing capacity at Black Lion helped somehow normalize the situation.
the situation. That means it introduced some degree of calmness in the residency program. So what was done after that is at the department level, in parallel with the EOC, we have a departmental committee that runs the residency program. As you all know, we have 3 affiliate hospitals, the Gandhi Memorial and Zawditu Memorial and the Black Lion Hospital. So what we tried to do in line with that, the EOC, is that we tried to manage our workforce. So the initial thing was to reduce the number of residents exposure to the clinical practice, so that we created a kind of like weekly rotation, so that residents will be off the work while keeping them safe. So during that time, because our infrastructure was paper-based, still it is, I mean, we are trying to be digital, but it was. So what happened was the quality of the service could not be maintained because the residents change every week. We could not continue the continuum of care that the training required, okay? So we have to really revise our decisions within, by the end of April. That program did not continue after the month of April. So we have to revert back to our older sessions. Rounds of trainings were given by the EOC, especially on the safety of our residents, which is a priority, and access to PEP, the PPE, was available even starting from the month of April. And staff members even generated resources. They raised funds among their diaspora friends, local friends, and they purchased PPE material to the hospital and the department, which was a very good act that our residents would be safe. The other thing is that clinical rotations, which are very important per the curriculum, were held for a while because our residents need to go to the other departments, but other departments could not accept our residents because of the international recommendation that residents are better have a fixed place for training. So we could not do that because we could not have anesthesiology training in the Department of Obstetrics. We could not have ICU training in the Department of Obstetrics. So we had to negotiate between different departments on how to drive the curriculum while keeping our residents safe. So what we did is we reduced our number of residents in the same hospital, but we increased the hospitals for such services, and that has been going on since then. Our, fortunately, by the due nature of the obstetric training, the caseload in obstetrics actually, which was 50% less in the month of April and early May, it increased, okay? And our obstetrics training is not that much affected. The caseload exposure is very good, even more than it was in the earlier years. But when it comes to gynecologic training, it is seriously affected. Number one, there is an international recommendation that electives should be postponed as much as possible. And number two, now we had to test gynecology cases, and if they are positive, definitely. And the patients were not coming. So we have a very serious gynecologic caseload reduction, and our residents were least exposed on that area. So what we did was we introduced a minimum requirement for residents to have a competency in gynecologic surgeries, and especially for our final year residents which graduated this year. What we did is we gave them a number of procedures that they have to do, and we prioritized them because they did not have the time. And we are fortunate that we had the needed number of cases in the 3 hospitals, especially Zawditu Memorial Hospital. I have to thank them, the administration. They have created a platform for our residents to have gynecologic care exposure, and they had achieved their competencies and they have graduated. So with still the posed threats by COVID, we have a fear as a program that the gynecology component of the training will be affected unless we have other means of acquiring those skills, which we don't have the infrastructure. Telemedicine, as has been raised, is a very valuable means of acquiring skill. SIM training is very important. We have one simulation center, but it is not well equipped.
And the hands-off training should be augmented by video surgeries and so on and so on. So the technology has to come really fast to make our programs strong. But another good thing is that the development of the natural protocol in caring for the COVID patients with pregnancy, it has really helped in the management of cases, okay? And it helped us pass that bad time. It was not easy to operate on COVID positive patients in a hospital that is designated initially non-COVID. Another very good thing that the college has developed is there is a home-based application developed for managing stress of residents, anxiety of residents. It's called a self-care application that's developed by the psychiatry department of the College of Health Science. It is a free application that is downloaded to any Android phone, and it helped a lot. I mean, it helped a lot, and now people have even a professional to talk to if they have such problems. So all the didactic programs initially were taken to the online. The university has purchased a Zoom function. So all our morning sessions, seminars, graduate management sessions, case discussions, everything was initially online. But the limitation that we have, if you remember, is that the power interruption was so frequent. Even if you have such a function, we could not use it fully. The other thing is the affiliate hospitals, even if they have the service, our residents did not have access to such a service. So residents had to have a personal cost incurred to have online trainings, which cannot be sustained for a long time. So with all those things, now we are reverting back to face-to-face. So infrastructure, internet access, with all the digital platforms we envision to live with COVID, it is like a mandatory situation that we have to have. In addition, I think as a resident, as a chair to the postgraduate program, I think nationally, we need to have our own new norm, new norm for training our residents, competent residents, future OBGYNs, because neither the international recommendations nor our current existing situation make it easier for the graduate program to run and achieve its objectives. So I call on ESOG and other partners that the residency program is a very critical program to continue delivering maternal and child health services. We are going to live with COVID. I don't think scenario 2 is going to happen. So I think everybody, partners, Ministry of Health, ESOG, and other associations, they should also be on board on bringing the residency training quality, because I don't think we are the only ones affected. I think other programs are also, I know ophthalmology post extended their training time because the competencies cannot be achieved. So this is what we did. Thank you very much.
Thank you very much. So for the next few minutes, we're going to discuss about the ways forward. I'm going to give you 2 minutes each, because I want to open the floor for Q&A and people to reflect on the issue. If you forget about the time, I will remind you. So Sister Zamzam, what is the plan for vaccination as a country? What's the policy directive with regard to vaccination? 2 minutes.
Thank you. Just first of all, I will try to see the future and then come to the vaccination issues in the context of COVAX countries. So first of all, I would like to thank you all the leadership commitment at all levels, from the national to the lower, at the community level. So the issues about the vaccine is, first of all, we try to keep about the future direction of the COVID-19. Our future direction is keeping the momentum, awareing the people, communicating about how the tailored communication about the risk communication and community involvement is in the center of the COVID-19. The other is just strengthen the FEM and the EOS center all is very important. The other things, awareness situations through the mass media, leaflets, and so on, should be continued because we don't know for how long this disease stay with us. The other very important thing is, and I try to mention is that the research is very important. In some country which already did research, and the findings showed that there is a collateral damage, especially related to the maternal and newborn, and nutrition health service also compromised because of that. They lost a number of lives. So in our context, it needs an evidence from the academia and the partner organization to decide our future plan and direction. The other issues is strengthen the all the expansions of the testing sites and having a resource at the level of the facilities. The other issue is just strengthening the capacity building of healthcare providers and all the resources, especially related with personal protective equipment like ventilator, essential logistics related with the maternal, newborn child health, and all the nutrition including, and even the blood and the blood product should be secured at all levels, especially the one which is needed in the hospitals. At that end, the central part should be just aware, and sometimes there is a condition which is happened not to donate blood because of the fear of acquiring the disease. We try to mitigate this all issue in the center of the future direction. The other to strengthen the situation is keeping in our policy. Our policy is revised on revision now. One of the part is handling the emergency situation and things which is important. Maybe things become aggravated. We don't know what will happen. And the other, a number of situations we are observing in our country nowadays, especially we can see the displacement, the different conflict, and so on and so on. So to avert that, especially with a certain of displaced community, from the displaced number of population, 4% of them are pregnant women. So we try to address that. The GBV is there, especially when we see nowadays in our country like Tigray, Wallaga, and so on. So we try to review that issue. When I come back to the vaccine situation, like other countries, around 213 countries are exposed for this COVID-19 problem. Out of that, the 54 countries in our continent, Africa, 8 of them are trying to cover their costs and buying their COVID-19 vaccine. For the rest, around just 45 or something countries, what you call it, the COVAX organization is trying to cover the cost, and in the near future, I think the April, mid and first week of April, some dose of vaccine of COVID-19 is introduced into our country. At the national level, the EPI program is coordinating this issue. That means already they develop the proposal and develop a training material how to provide the vaccine, and just they get some support and ready to introduce the vaccines, which is based on the assumptions of the frontliners, like healthcare workers, teachers, the comorbid populations, and with that assumptions, the COVID-19 vaccine are introduced into our countries. So it needs a resource further. Maybe our Minister Dr. Liat Addis is giving a press release on these issues. The past 1 or 2 weeks, you can see the source and browse and see the detail of the COVID-19 vaccine. Thank you for just reflection. Thank you so much.
Thank you very much. Dr. Yirgu, what should be the way forward in leading a health facility? What do you recommend?
Just to supplement the vaccination effort, as I'm a member of the NITAG in the coming 2 weeks, we are going to discuss about the vaccine and introducing also the COVID vaccine, particularly to the health workers, and then the needy ones. So this is clearly on the horizon. I'm sure in a very short time, the vaccine will be available in the country. So what do I look forward in my facility? We have definitely worked out a very clear plan. We have submitted that to Federal Ministry of Health. We require assistance around of 50 million birr, because this is an additional cost incurred by COVID treatment. The way we are managing things is that, last year, like 2012 fiscal year, there is no additional budget increment for COVID services. We just pulled whatever resources available. So we need that resource. Again, we need to beef up our testing capacity and then shorten the turnaround time to less than 12 hours. This is what we are driving for, because this is essentially very important, particularly to address the surgical backlog within the hospital. Then the next thing that we are going to do is still seriously under consideration. We have to make a series of renovation within the hospital. We have already planned for 21 wards to be patient-friendly and suitable for staffs to work in. We'll go full gear toward this 100% digitization of the hospital. Mahalit complained about paperwork. I'm sure in no time, obstetrics will be 100% digital. And then we go for gynecology and then all the other wards, because one of the issues that we are having is we have to fully automate the liaison process, which is quite a bottleneck in our service provision. So once we make that process digital, then we can link the whole wards to be 100% like paper-free. So all the requests, lab services, imaging, inpatient and outpatient services will be software-based, including the parthographs will be software-based. That we are going to do in a very short time. PPE, we are going to push hard because this has to come directly under PMAID of Federal Ministry of Health. We know what the bottlenecks are. We know what the issues are. Our colleagues at the ministry also know that. But PPE availability is a topmost agenda in order to address the fears of our health workers. I think essentially these are the things that I look forward.
Thank you. Ato Abebe, so what are the minimum requirements, technological requirements to proceed and further strengthen what you have already started? What lessons have you learned, and what do you think the future would be with regard to such approach of service delivery?
Okay, thank you very much. I think when you are talking about the way forward, sometimes when you are thinking about telemedicine, the first thing that comes to our mind is technology. But telemedicine is not necessarily only technology, it's beyond that. So the telemedicine or telehealth that requires the transformation of the way we are, serving our people. That means the culture, the practice that we are doing, it has to be changed, it has to be transformed. Then technology will be a backup. So otherwise, telemedicine doesn't mean that just simply using technology, unless and otherwise we change the practice, it mean nothing. So that is the most important thing. So as a lesson or as a way forward, telemedicine should be considered, or telehealth should be considered as one of the integral parts in all things that we are doing, as we mentioned, in the teaching, in service delivery, in all aspects, telemedicine should be the way to go. If you see the technology, the financial industry, they are taking advantage of that. If you see even just in our pocket, just we are receiving a lot of information and we are managing our accounts, but are we managing our health situation using this telemedicine approach? So this is the most important thing that we have to consider. As I have tried to mention earlier, if you are talking about, the internet penetration rate in Ethiopia context, there are 23 million people still using, internet. That is, every year, 13% growth. That means new 3 million internet users are coming up. So this is an advantage for us. How can we use this as an opportunity to integrate telemedicine or telehealth? If you see the social media on a yearly basis, right now, around as of January 2021, 5.6 million people are using, social medias. So every year, 500,000 new additional users on social medias. So how can we use the social media in one or another way for telemedicine or for telehealth? Okay. And again, the mobile penetration rate is around 40 million. So all these are opportunities we have right now. So the most important, the message is how can we use this resource in our healthcare industry? That's why I'm saying transformation is critical for us, the way we are thinking, the way of practicing. So this is critically important as a lesson that we have to go forward. So the other thing is the resource is critical. So I think telemedicine requires some kind of the minimum requirement, for example, internet. The minimum requirement, might be mobile phone. The minimum requirement, computers. So this might be something. For example, Marisops and in General Health, we are partnering in supporting the public sector. We are just in Adama and Yekati Hospital, we are establishing a telemedicine setup context. So that gives an opportunity for doctors or for providers to use as an opportunity. And again, I think in General also using in Walaita and Gondar Hospital. So this is the opportunity. So that the minimum requirement that we set up is, internet and, just computer. That's period. That's the minimum. That's why I'm saying in the morning, in my previous speech, we have to start on what we have. And we have to we have to start on what we know, and we have to build on what we have. We have something at our hand, so that has to be something that we have to use if you are thinking to integrate and transform our healthcare industry in order to reach as many people as possible during and after COVID. So that is the message which I would like to say. And e-health already, Professor Sanechi mentioned, e-health is the way to go. Yes, absolutely. So that's critically important. E-health, MS, whatever we call it, technology is the second wind of our service delivery transformation. The first wind is the practice, the culture. Unless we change our culture, unless we practice, it doesn't mean nothing when we're talking about telemedicine. So telemedicine has to be integrated with the culture, the practice, and the way we are thinking to deliver services.
Thank you very much, Dr. Mahlet. I'll give you 2 minutes to reflect on your thought on what should be done by relevant stakeholders to mitigate the impact of the pandemic on the teaching learning activity.
Thank you very much. I think what COVID has posed for us is an opportunity because it is a mandatory, I think, to introduce flexibility and creativity in our training of our residents and the future OB/GYN. And this has to bring in no compromise to the quality of education so that the quality of service will be maintained. So I think the primary stakeholders are the universities. I think we need to revise our curriculum so that even if the curriculum is competency-based, I think the way it is implemented has to be so that we have to go to implementing a competency-based education system in such a way that we have an achievable target milestones for each level of residences so that we align our services with it. So the universities and the Ministry of Higher Education and Moshe has got such a responsibility. The other thing is coordinating resources among training institutions, partners like IPAS and other partners is very important because to have e-health, you need an e-education. So they need to be paralleled, and resource mobilization, resource deployment, manpower assignment has to align with that. So there needs to be a coordination to have a meaningful impact on the education and later service. Overall, I think to be driven by technology or to be assisted by technology, there needs to be an investment on the infrastructure and the experts, the ICT experts and so on, to assist the education process so that what has been tried in other developing countries can also be done in our areas. Regarding why we are working with COVID, I think the vaccine news is a very good news for all the workforce, especially the OBGYN community, because I think we are the second most affected next to nurses. In my department, 5 of the 22 faculty and 17 of the 84 residents have been COVID positive. So the magnitude, I'm sure, when it comes to the emergency department and so on, it's going to be huge. So we cannot continue like this. So the vaccine is a very good tune. I think this is one of the interventions that we hope will prioritize our residents so that the training can continue. The other very important for the society and the academic institutions is that COVID requires a high engagement and involvement of the consultants in monitoring, mentoring, coaching of the residents. Teaching cannot be continuing like it used to be. The consultant should be the leader of the training. I think the curriculum has to see to it that that is done so. So the other thing is, as Sister Zamzam said, research is very important. We have to generate our own local research output on how we are going to continue with COVID, and the input has to also be shown in the curriculum change and implementation of the program. Thank you very much.
Thank you so much. You have raised very important issues, shared experiences. Now, I'm sure the audience would have so many things to reflect on, to ask. And we have some questions from our virtual attendees as well. So I'm going to give 3 chances. And then we'll come back to our virtual attendee questions. So 3 people. Okay, Dr. Brahanu, Dr. Malede. Yes, yeah, Dr. Mangus.
Okay, thank you. I really congratulate.
Yeah, please tell us your name and your institution, and then who you want to ask, who you actually want to ask from the panelists. Thank you.
Dr. Brahanu Kabede from Yekayit Asraolit Hospital Medical College, OBGYN, and probably the questions can go for everyone because it's a general one. And when I start with some of the innovative approach from male stops, okay, it's interesting, okay, using use of telemedicine and the like. But what I see is these activities are very fragmented, okay. There are some activities at male stops. Some hospitals have already automated or digitalized their services. Some are planning to digitalize or automate the service. And at times, the worst scenario, as Dr. Mahalit said, we are reverting back, okay, to face-to-face discussion. While we are in the third scenario, the situation is worsening, but the activities are really fragmented. So this should be coordinated as central at national level. So I don't know. Also mentioned from people from many stops. I didn't get a clear policy from the ministry, and I didn't see any coordinated action. Otherwise, such fragmented activities probably ultimately will not end up in result. And this is the situation. Okay, some are continuing, some are reverting back, and even though we are in the worst scenario, we are coming to some at times to face discussion at the previous. So this is paradoxical. So I think it is a high time that we should have a coordinated and harmonized activity at the national level. And I want to see the reflection from all presenters concerning this issue.
Okay, thank you. So I have just a couple of questions. The first one is for Ato Ababa. You've mentioned the importance of telemedicine as an important strategy, but do you think it's going to be feasible in this country, given that it needs a very high resource in terms of like telephone, computers, internet, and also the literacy of the patients themselves? They are not literate to respond for this kind of things. So, considering health centers, hospitals, districts, and so on, is this going to be a feasible alternative? The other question is for Dr. Yirgu. What was the experience at Black Lion Hospital in terms of re-engineering the process pathway of the patient flow to prevent nosocomial transmission or intra-hospital transmission? That is, intended to protect the healthcare workers. Or did you continue in the older pathway, or did you re-engineer the pathway that can be a lesson for other facilities? And maybe one general question is, there is no dedicated center for health professionals like us, okay? But we are still continuing working. Now, if a single OB/GYN gets sick critically, we don't know where to get. We are not sure that we are getting for free this service. For example, earlier the state minister said that we are short of the ventilators. We are at risk, but there are shortages. So what is the plan at hand in order to give priority for healthcare professionals?
Thank you. My name is Mangustu. I came from CERT. So I really congratulate all of the presenters on the stage for their enlightening and a very good presentation. It was really provoking. So it's not a question, it's more appeal to the Ministry of Health and also other colleagues here with regard to the severe impact of this COVID impact on the service outlets, overall service outlet, but particularly the SRA service outlet. As Dr. Yirgu clearly said on the presentation, there was really a struggle to recover the status of the services in most of the service outlets in Black Lion Hospital. And it was really severe when you look at the situation outside of Addis. Now, because we are very close to Addis, things are very easy to recognize. But when you look at the first scenario back in April and March, there was enormous knee-jerk kind of response from all hospitals, and they literally closed all the services, and they started to kind of get prepared for the upcoming COVID. Most services are evidently recovered, but in some of the places the SRA services are still struggling. I can mention some names, particularly big hospitals outside of Addis. They have completely dedicated their previous SRA service outlets, particularly delivery rooms and antenatal care clinics and family planning clinics for non-symptomatic COVID cases and even symptomatic COVID patients. And for me, I see that the SRH services have been taken as the least priority for most hospital administrators. So we need to appeal this to Ministry of Health, and also our colleagues, should come, in the front to, tackle such issues. So thank you so much.
Thank you. I want to add two questions from our virtual attendees. One is for Dr. Yirgu. Do you see any role of professional societies like ESOG in supporting health facilities to mitigate the impact of COVID? And Dr. Ababa, do you see any possibility of scaling up your experience to the public system? What role can Ministry of Health take in doing this? Yeah.
Very important points have been raised. I'll try to reflect on some of this. Dr. Brown talked about fragmentation. Definitely this is going to be inevitable. Inevitable because this is a kind of exercise that takes a lot of resources. So you want to have an access to Zoom, unlimited time, then you have to buy it. It doesn't come for free. Google Meet has to be subscribed by the university. Now that's the subscription have run out. So rather than having an online classes, then departments have to revert to face-to-face meetings. Again, digitizing hospitals is not an easy feat. It's quite expensive. It is quite a resource as well as technology-intensive exercise. Definitely, all of the hospitals are not on equal footings. There have been a number of efforts by Federal Ministry of Health to adopt or in fact modify a software that has been essentially developed for HIV and TB care to do all sorts of services. This has gone to 3 rounds of versions, but it has not fully matured. So if that really matures to be good enough for practical use of outpatient, inpatient, then probably digitizing hospitals will be the way forward. Is telemedicine feasible? Yes, it is feasible. In fact, I have not talked about that, but we have quite a good experience on telemedicine. I made the first presentation to our Wednesday morning meeting, that is with the ministers. And then following that, a telemedicine implementation guideline has been developed, because before that, there was no telemedicine guideline. In some of the departments, for example, up to neurology, up to 70% of hospital visits have been reduced because patients were accessible. And some of the patients who requires a refill, they just get their prescription. They don't stay within a hospital facility. So their contact with our other patients would be quite limited. So areas like antenatal care, it's unavoidable. I mean, they have to come for a hospital visit because they have to get an actual care. Otherwise, for refill, advices, etc., particularly in chronic care clinics, telemedicine is quite an important resource. Did we do re-engineering? Yes, we did. In fact, initially, when COVID hit the country, because there is essentially no guideline from the Federal Ministry of Health, the only resource or resources available were the Chinese experience, the Italian experience, etc. And the Chinese, by the way, had produced one very important book, handbook on management of COVID, that talks about even floor management, flow management, etc. We have done according to their advice, but later on, we found out that we don't need to have a fever clinic. That is the Chinese advice. In fact, I could say we don't need also temperature monitoring at the gate, because I found it, again, evidence-based. It's a wasteful exercise. We have not detected a single case, febrile case, from our temperature measurement. We have measured over 1 million individuals, and no single fever record, and no detection of COVID cases at the gate. So initially we had all sorts of flow management, but now we have essentially reverted to the usual way. Although I say this, we have got 5 gates. 2 of the gates are absolutely dedicated to patients, and 2 of the gates are dedicated again to the staff, so that mixing is avoided. And then at all the gates, because we have to comply with the advisors from the ministry. We are doing still temperature monitoring. This is more of a symbolic rather than kind of useful exercise. Now, do we have a dedicated facility for health workers? Unfortunately, no. I wish and I pray that you don't reach there. But if you reach there, you will see how painful it is. I mean, you literally beg. Okay, you literally cry for every facility to take a patient. Okay, and then you reach there. We have recently an experience. You know, a patient was sent to one of the COVID treatment center, stayed over 4 hours, bargaining at the gate, but then finally it was chased away because they said there is no ventilators. Okay, so if you have got a critical patient who requires ventilation, that would be exceedingly difficult. So probably one of the things that we can possibly do is make arrangements within our respective facilities. Okay, because the most difficult thing is the transport. In fact, the majority of patients would be in a very dangerous position during the transport process. Okay, not in the facility. So probably, I mean, we have to look into establishing corners for our own sake. So if a colleague of ours gets sick, requires support or oxygen support, etc., we can avail it. Any role for ESOG? Definitely there is a role for ESOG, because we literally import everything. I mean, all the knowledge that we have is imported. I mean, we cannot keep on importing everything. I mean, some of the evidences have to be adapted to the local context. So it should be, you know, like ESOG could be a national organization that collects local data, revise you know, available evidences outside, and then adopt it to a local context. You know, in a country where we have got like 45 universities, I mean, ESOG could be a central hub to organize, you know, these entities so that we talk about the same language. Is SRHR suffering? Definitely, it is suffering for a number of reasons. But you know, hospitals and ESOG, particularly ESOG, has to advocate for availability of this essential and life-saving services for women. I thank you.
Thank you. Dr. Ababa, you can have 2 minutes.
Okay, thank you very much. Starting from the question from the virtual participants. In terms of scale up, absolutely, yes, we are intending to scale up. As I have tried to mention earlier, in the public facilities, and gender health is supporting Walaita Sodo and Gondar, and Mariso is supporting Katiti and Adama, just a kind of center of excellence for such kind of businesses. So we are going to scale up such kind of things in the future. And at the same time, when we're talking about telemedicine, doesn't mean that, you know, in each and every facility we have that kind of, you know, services. But there should be a mechanism whereby women or the people at large to access services in one another way. So scale up is the most important thing. I think Dr. Hugo, as mentioned, there is a policy, but sometimes, you know, having policies is misleading. There are countries who have no policies, but they are doing excellent job in telemedicine. But in our context, once we have, you know, a policy, we say that we have done the job. That might be something, it has to be transformed. That's why I'm saying that, you know, the mindset has to be transformed. So from that point of view, COVID influenced us to improve our technology literacy. And the technology literacy, again, it influences us to improve health literacy. So the health and technology now is integrated because of COVID. This is the most important thing. So in terms of importance, definitely this is important, having technology, having telemedicine. One important thing, when I'm talking about telemedicine, it seems, you know, more of a real-time patient and doctor interaction, particularly on clinical services. When the other version, telehealth, it's a little bit comprehensive than telemedicine, which including, information sharing, referral, a lot of things. So from that point of view, in our context, it's more of both telemedicine, telehealth can be applied. So that's why I'm saying that, what we have right now, for example, if you are talking about in the teaching institution, if you are talking about what you call it, telemedicine, what do we have right now? We shouldn't expect everything in order to start, telemedicine at larger scale. We have to start on what we have right now, because as I mentioned, it requires the minimum is computer, internet, and some kind of things. So from that point of view, in terms of scale up, in terms of scalability, yes, that should be something to happen. As Dr. already mentioned, it's feasible, or we have to make it feasible, telemedicine, because that should be the way to go. And then this is the most important thing, which really, the question is great, but I'm saying that, yes, if it's not feasible, we are not, generally, we have to make it feasible in one or another. The first question is, yes, definitely there are different actors working in telehealth and telemedicine, but in a fragmented approach, that's the best lesson. Definitely, I agree with you, Doctor, and then I think this is the way to go. If we are doing a telemedicine or telehealth in one another way, how can we bring together and generate lesson? And we have to make it scale up and scalable.
Sister Zamza.
Thank you. There is two issues raised for Federal Minister of Health. One thing which is about the telemedicine, digitalization of the facilities, issues not raised by the ministry during the presentation, but most of in our plan and in a policy, there is digitizations of the facilities and all what we are working around that the data and all things are just complemented or strengthened by digitization. So in our plan, we have it, digitization. The other issue, which is which is about the use of technologies, innovations. What we learn from the COVID is just currently every meeting, most of the meeting is conducted through Zoom. That is one of the things which is opportunity. I think I can say that opportunity, which is just forcibly exposed to technology, and we try to sustain it. Because of that, we try to mitigate the number of situations, especially problem related with SRH. To solve that issue, things we try to communicate through Zoom. So innovation and digitization is our center of all service, I can say that. The other issue with ventilation, things raised, how do you see the ventilation issue? In the evening, His Excellency Dr. Daraja Jaguma also raised this issue. Still, we have a shortage of ventilator in our hospitals. The Minister of Health is trying to plan just requesting different national and international organizations for the support of ventilation, and try to support the domestic innovative different schools and different colleges for the just development or formation of this ventilator. So we don't know what will happen in the future with such a behavioral issue. We are not sustaining what we get at the when we see when we go back and see the March and April, the people are shaking and fear, and they try to use all the safety measures to protect themselves. Currently, when you go out of Addis, you become shocked. Really, most of the people is not using the face mask and not keeping all the safety measures. So we try to, the first issue, because we are a resource limited countries, we are focusing and strengthening our risk communication strategy, strengthening the risk strategy, and all the community involvement and the resource mobilizations are the center of the service. Because I don't know, for no one knows or no one forecasts for how long this disease stay with us. So there is a plan to increase just to increase the number of ventilators in hospital in our country. There is a plan to buy or request a donation. So we have it all the digitization, technology, the innovations, and also the just procuring not only the ventilators, but still we have a number of medical equipment which is important for us. And still, before even the COVID, there is a shortage of a number of medical equipment, not only ventilator. So we are planning, we did for 2 to 3 years forecasting to procure all the medical equipment, including the ventilator, but ventilator is a priority by just currently we have such a COVID problems. So those numbers, certain number of populations needs a ventilator. As he said earlier, His Excellencies, there is a shortage of ventilators in the hospital. Because of that, even just before a week, we lost 2 the popular peoples in our country. So ventilator for this pandemic is the center of the resource for us. Thank you so much.
Thank you. As much as I want to give more opportunity for audience to reflect that, the time has limited us, but feel free to put your inputs on any platform for ESOG, what you want the ESOG to act. Your expertise, share with us on all platforms. Use email, the virtual platforms, anything. Okay. Thank you so much, our panelists, for accepting our invitation and sharing your immense experience on this issue. Thank you very much, and we applaud our panelists and the audience for your great attention. Thank you so much.